Hey everybody, I'm Anton Lishmanov. I'm a relatively new addition to Arkansas Heart Hospital. My special interest is in interventional heart failure, so I'm kind of combining the ability to do procedures and treat patient medically through the whole spectrum of their disease. So I'm going to talk about sort of state-of-the-art therapies for heart failure. Obviously, in 12 minutes, it's really difficult to do, but I'll try to kind of give some high points and sort of get the message across. So this is brief agenda. I'm not going to talk about the heart failure with preserved ejection fraction. This is tedious, nothing works, and it's much more difficult to treat. So I kind of chosen the easier topic to talk about. So I'm briefly going to mention ARNI, SGLT2 inhibitors, IV iron, what interventions can be done for people with heart failure. I'm going to talk about sort of what guidelines are saying, what are the new guidelines, talk a little bit about clinical inertia, and when to refer people for more advanced specialists, somebody who is specializing in heart failure. So let's start with, everybody knows heart failure is bad, mortality is still bad, no matter what therapies we have, and we have a good amount of good therapies that do work. So the first thing is neprilysin inhibition. So the new drug on the block, available since 2015-2016, is Entresto, or sacubitril/valsartan. So idea behind this that we have a lot of vasoactive peptides in the body that promotes vasodilation, natriuresis, lower the amount of fibrous tissue in the myocardium, and all of this are cleaved by or metabolized by neprilysin. So the Entresto, or sacubitril part of it, sort of prevents neprilysin from working, inhibits its work, and so all these beneficial substances build up in the body. So what is the evidence? So again, the high points, so this is the landmark trial, Paradigm HF. So they compared the sacubitril/valsartan against the staple therapy, enalapril, been known to work for years. And surprisingly, in very well managed patients, sacubitril/valsartan was significantly better compared to enalapril. So heart failure works really well in chronic heart failure. Then there was another study, Pioneer HF. So this where the Entresto was compared to enalapril in a setting of acute heart failure. So people were started on the medicine in the hospital. And again, significant benefit, less heart transplants, less heart failure readmission, less death from heart failure. So the newer kid on the block, and unfortunately I feel like a lot of data that came out about SGLT2 inhibitors came unnoticed, because a lot of the data was coming in during 2020 and a lot of things went unnoticed during 2020, and probably going to keep going like this if we're going to be in pandemic again, or not again, as we are now. So there are multiple effects. So in essence, what those drugs do, they block a sodium and glucose co-transporter, and you pee a lot of sodium, pee a lot of sugar, losing obviously volume and reducing your sodium load in the body. But there are multiple other effects directly and indirectly on the cardiovascular system. So some of them are listed here. Now, we can talk about pathophysiology for a whole day, but the important part is, do they work? So this is the DAPA-HF trial. So they used Farxiga, or dapagliflozin is the generic name for it. And in well-managed patients on good background medical therapy, Farxiga was able to reduce death from heart failure and reduce heart failure readmissions, or admissions for heart failure. The next one is empagliflozin, or more known as Jardiance. Same thing, beneficial effect, wasn't as significant for the death as an outcome. However, it did reduce the composite endpoint and did reduce admissions for heart failure. So this is the expert consensus. This is the recommendations from ACC when you're starting patients on either of those medications. There are things to consider. If they're diabetic, they're well controlled, you need to reduce the dose of their diabetes medicine. So if they may get hypovolemic. So I had a patient who was on 100 milligrams of torsemide last Friday in clinic. So he came in, started him on Farxiga, added some other therapies as well. He's like, if I take less than 100 of torsemide, I'm going to swell up. I decreased his torsemide significantly to like 20 milligrams. Well, now he came in dehydrated still. because those drugs work and they really maintain euvolemia in people, on top of other beneficial effects, obviously. And the other thing is you need to consult patients about possibility of genital fungal infections, because that's something that would be unusual. Oh, and the very peculiar thing is euglycemic ketoacidosis. So the blood sugar is not necessarily high, but people can get ketoacidosis, and they need to be consulted about the symptoms: unexplained nausea, vomiting, abdominal pain, kind of feeling lousy. So next thing is IV iron. So I probably, I don't know, Dr. Raja probably prescribed significant amount of IV iron in the hospital too, but I prescribe a lot. And the reason for this is this. If you replace iron, because iron essentially is in the myoglobin and hemoglobin, in the muscle tissues, in the myocardium, in the blood, and replacing IV iron helps people feel better, their functional class goes up, improves. And there is new trial that came out again last year, not last week, that demonstrate that people even get readmitted less frequently if they had their iron stores repleted. So this is ferric carboxymaltose formulation. So I'm an interventional cardiologist. What are the interventions can be done for people with heart failure? So mitral clip is one of them. And so this is a percutaneous mitral valve repair. And the landmark trial that came out was a co-op trial that had phenomenal results. What they did, they compared 300 patients that received best possible guideline-directed medical therapy for heart failure. And this is not like correct 3-1-2-5 twice a day. Those people had blood pressure of 80, were dizzy when they stand up, they were on maximally tolerated medical therapy driven by a heart failure physician, like advanced heart failure doctor. And they compared these people medically managed with severe mitral regurgitation secondary to LV dilatation and remodeling, and medical therapy plus mitral clip. The results were astonishing. So number needed to treat to prevent one death was 6. So this is probably the level of effect you get from penicillin, antibiotics for infection and things like that, or clean water or clean air. So the key point though is, first, good background medical therapy. If that doesn't work, you go for mitral clip, you get excellent results. So the second thing, again, don't forget that the staple of interventional cardiology is myocardial revascularization. And unfortunately, a lot of times people kind of forget it. And a lot of patients I'm seeing, they hadn't had a cath in a while, they hadn't had a stress test in a while, and their heart failure are getting worse. Well, we have a really good data for surgery that for people with severe systolic LV dysfunction, you revascularize them, they do live longer, they feel better, and that was so-called Stitches trial that been a while around a while now. Well, the problem is that a lot of times, this is the data across the nation, 1 out of 10 patients, or only 1 out of 10 patients, gets tested for ischemia, myocardial ischemia when they present with their index admission for heart failure. And so you have all these people walking around who didn't get appropriately tested, and so I feel like we could be doing a better job on this. Okay, so now, again, we don't have the data for PCI that we anecdotally know. If you fix somebody's left main, their ejection fraction goes up, they feel better, they live longer, their heart failure gets better. Now, we don't have a randomized trial to support this, but we are seeing more and more patients, and Dr. Sherbet and Dr. Raja, they were talking about high-risk PCI with Impella support, and the hospital was doing, Arkansas Heart Hospital, doing an incredible amount of those very high-risk complex patients who have no other options. So now we also expanded our armamentarium to other devices. So Dr. Raja and myself recently did the first case in Arkansas that the patient with a very complex anatomy and a very sick was supported by percutaneous, other type of percutaneous LVAD, was a tandem heart. So this is much more powerful device. And we done some ECMO cases since that time. So we're expanding our options to treat this very sick people. So, well, this is state-of-the-art treatment. Evidence-based therapies are very well articulated, they're well known, they're endorsed by guidelines. Everything is laid out, understanding. We have this multiple, stages of heart failure. If you have stage A, you do this. If you have stage B, you do that. So complex algorithms and, everything should be great. Why are people still suffering? So, actually, before I go there, this is the updated consensus pathway for management of systolic heart failure. really, if you treat those patients, I really encourage you to read through this because they sort of really dumb it down and kind of go over the most important topics. And the topics are, how do you initiate treatment? How do you escalate treatment for heart failure? How do you switch patients with medications? When do you refer? How do you treat comorbidities? How do you deal with insurance companies? How do you improve patient adherence? And they actually just laid it out really nicely. To the point, there is an app for everything right now. So you can even have an app that's kind of based on the guidelines that tells you, okay, what could be your next step? So with this said, many eligible patients with heart failure and reduced ejection fraction never receive therapies that are shown to extend their life and improve mortality. So this is the data from 2018 again. So it's 10,000 patient sample. Don't even look at the slides or graphs. The bottom line is this. When they looked at it, 1% of patients was on target doses of, they didn't have Farxiga or Jardiance at that time. 1% of patients were on target doses of all 3 indicated therapies. 1%. And only 25% of patients were on any doses of 3 indicated medications. And that's the data across the country. And so I feel like that's where we're failing our patients, unfortunately. So my thing is, we need to really fight with the clinical inertia because on one hand, it's difficult. Clinic is busy. There's always side effects from the medicine, and you have a risk of commission. So you can have a side effect from the medicine. You can have some other issues. It's difficult to get people on the medicine, insurance issues. But if you don't do this, you potentially may reduce survival for your patient. You will deprive them from opportunity to feel better, live longer, and so I feel every time that you see the patient, that should be a point when you can encourage escalating of medical therapy. So recently, people analyzed the few trials that Landmark trials and came up with the algorithm. So there's guys from Northwestern University and UCLA, and what they suggested, and I kind of do pretty close to this in my practice, probably not every week, though I kind of starting to be more and more aggressive nowadays. But the bottom line is, from the get-go, when the patient get diagnosed, get them on MRA, spironolactone usually, 25 milligrams, get them on low-dose Entresto, get them on SGLT2 inhibitor. Most of the patients will tolerate that, even if they have baseline hypertension. Unless they're in shock, frankly, cardiogenic shock, they will tolerate those medicine. You start them on low-dose beta blocker. This one I'm a little bit skeptical because I usually diurese them really well because they may decompensate if you start beta blockers too early. Then they're all on all the guideline-direct therapy, and then you bring them in a week, up-titrate, bring them in a week, up-titrate. In 42 days, you will get almost at target. At that point of time, you know that what's happening is they will have rapid improvement in how they feel. So, recent example, patient was super hesitant, her blood pressure was 95, she was on high-dose diuretics. Up her Entresto from quarter of a tablet to moderate dose Entresto. So, and I'm calling her to check on her because I was really worried about her blood pressure. And she's like, Dr. Lishmanov, I was about to call your office to say how much better I feel. So, and if you stack all these therapies up, you probably will need to treat about 4 patients in order to reduce their mortality and make them feel better. So, in a nutshell, so you have this fantastic 4 staple therapy, and if they're not working, consider electrophysiology referral for AFib treatment, CRT devices, consider revascularization, consider mitral valve repair for indicated patients, kind of the central diagram for this thing. And the last thing is, when do you refer people for advanced, sort of consultation with a heart failure specialist? And the acronym for this would be I need help. And this is IV inotropes, persistent OHA high classes 3 and 4 despite optimal medical therapy, end organ dysfunction, ejection fraction stays low, they get defibrillator shocks, they had frequent admissions for heart failure, usually more than 1 admission. You shouldn't be admitted for heart failure. If they have edema despite diuretics, low blood pressure, and when you have to peel off their guideline-directed medical therapy, that is one of the bad signs. So, thank you very much for your attention.